Welcome everybody to Spine Time, Stem Cells for My Spine, Regenerative Treatments that May Put an End to Back Pain. My name is Neel Mehta. You may have seen me in past videos. I'm one of the co-directors here in the Center for Comprehensive Spine Care at Weill Cornell. And I'm joined by my two very close colleagues, Dr. Jaspal Singh, who is also a co-director of the Spine Center and a vice chair in rehabilitation medicine at Weill Cornell, and Dr. Roger Härtl, our director of the Spine Center and a professor in neurosurgery. Both of these gentlemen need no real introduction. They are well known in the field, and I'm fortunate to call them my colleagues. As a reminder, we will have a few slides, but the idea here is to have a open discussion. Many of you have shared questions ahead of time, and I will do my best to get through these questions today. But in the beginning, we will spend a little bit of time to go through some background on regenerative medicine that I think will be helpful for a baseline understanding of what it is. There will be a recording of this presentation that you'll be able to find on our website. And I hope that you will continue to sign in and join us for future conversations. So with that, I turn it over to Dr. Härtl and Dr. Singh to lead off the introductory portion.
Thank you, Neil. So welcome everyone to September 16th on this very exciting topic on stem cells and regenerative medicine. Just a little background on our center. If you have not seen us here, we are the Weill Cornell Medicine Center for Comprehensive Spine Care. And what's beautiful about our center is it employs many different specialties and physicians and healthcare providers coming from different disciplines working together to find a solution for patients. Including all of these things you see on the gears: neurology, complementary medicine, spine surgery, pain management, rehabilitation medicine, and mindfulness. So all of us work together to try to help you, the patient, achieve successful outcome. So as Neil mentioned, my name is Dr. Singh, Ricky Singh. I work in the Department of Rehabilitation Medicine, and my co-presenter today is Dr. Roger Härtl, who's the professor of neurosurgery and director of this center. So very excited topic, and hopefully it's educational for everyone. So stem cells, regenerative medicine, it's a very exciting topic. We see a lot about it in the media, maybe on advertisements. And the fundamental thing with regenerative medicine, everyone wants to feel younger. They think this is the fountain of youth. And really the term regenerative medicine may not be the correct term. Really it might be restorative medicine. Because in the lab, excuse me, in a petri dish, we are able to regrow cartilage. Like this diagram here in the corner, you can grow ears, you can grow a knee joint. But in the body, it becomes a little more difficult. So we can't really regenerate cartilage, excuse me. However, we can restore some of the structures around the joints, around the spine, to support the body in achieving its functional outcome. So everyone asks, what are stem cells? And I always use this analogy. When we were all babies and children, we had aspirations to do a number of different things. We wanted to be a doctor or a police officer or a chef or an astronaut. And why that's relevant is that when we were babies, we had the potential to do many, many different things. But as we age, we start specializing into one direction. So for most of us on this panel, we specialized into medicine through medical school and residency training and fellowship. And that's kind of what happens with stem cells. So when you take an embryonic stem cell, which is the embryo, which is a baby, that cell can turn into anything in the body. And there's a bunch of regulations and ethical considerations when talking about those stem cells. So we don't deal with those. We deal with adult stem cells, which is cells that are already specialized into becoming something, whether it's muscle, whether it's bone, whether it's cartilage. So there's always a concern of, if I get a stem cell injection, can it turn into cancer? The short answer is probably not with the cells that we are talking about, because they don't have what's inside of them to become cancer. If we went back and got the embryonic ones, yes, that's possible. But again, in the United States, we don't use those for treatment for these conditions. So where do we get stem cells? They are floating in our bodies. We all have stem cells. When we cut ourselves, when we break a nail, our body can recover and our body can heal. And that's what stem cells do. So they're circulating in our blood. We can get something called platelet-rich plasma. They can be taken from placenta tissue, which is donated. So those are the cells that I mentioned before. Or they can be taken from your adipose, your fat, or inside your bone marrow. So we have really high quality cells in those areas. The challenge with stem cell treatment, first and foremost, is figuring out where all this pain is coming from. And that's what we do at the center, using a history, a physical exam, imaging, input from all these different specialists to figure out where the pain generator is, so then we can start treating it, whether it's with epidural injections or ablations, steroids. You know, steroids is another topic that comes up, and steroids are anti-inflammatory, right? They make things feel good because we suppress inflammation. But the problem with cortisone is that it doesn't just affect the joint, it affects the entire body. So patients with diabetes, their blood sugar goes up. They can lose hair, they can gain weight, their bones can get brittle. So steroids have some bad adverse effects, which is why we're limited on how much steroid we can do. And that is why this field of regenerative medicine and stem cells is so exciting. One of the areas where we focus a lot of our research is the disc in the spine. You can see these bones in the middle. In between the bones, you have these small little discs. They're like jelly donuts. Sometimes they degenerate. And while 20, 30 years ago, and Dr. Härtl will talk about this more, the treatment was likely a spine fusion or a big surgery. Nowadays, we're looking for minimally invasive options. And one of those is to inject some stem cells from the bone marrow into the disc. That is something we do here at the center. We do it collaboratively. We are tracking outcomes data and seeing how patients do. Safe procedure, it's outpatient. We do it all, take the bone marrow, centrifuge it, and put it right back into the disc. A pretty simple process. And so far, our outcomes are really nice, which we will publish soon. So that's kind of the overview of regenerative medicine and stem cells. I'm excited to address some of the questions that you guys have, and I'll pass it on to Dr. Härtl to talk about how he uses regenerative medicine in his practice.
Roger, you're muted.
Yeah. Thank you, Ricky. Thank you, Neil. Thanks for having me here today. It's a great pleasure to see so many participants in this webinar. And Ricky Singh, who's one of my esteemed colleagues, of course, and co-directors here, gave you a really nice overview over regenerative or restorative medicine and some of the basic facts. I got involved as a surgeon really at a little different stage, because what I see in my practice can be pretty scary. If you look at the natural history of patients who have spinal problems, and I try to show that here on this slide. You can see all the way on the left side, you can see an MRI scan of a patient with a herniated disc, and I don't have control. Maybe Ricky, you can point out the herniated disc. And some patients who have herniated discs, as you all know, will require surgery if they have intractable pain or have a significant neurological deficit. Unfortunately, the surgery is not always the last problem or the last encounter with medicine for those patients, because a lumbar disc herniation, even though it can be treated very, very successfully with an operation, may down the line be associated with some delayed problems, such as degeneration of the disc and low back pain. As a matter of fact, having a lumbar disc herniation, and there were just some papers that I reviewed recently on that topic, having a lumbar disc herniation is a significant indicator, unfortunately, of you having potentially more back problems down the line. And what could those back problems be? It may just be degenerative disc disease with low back pain, but it could also be, as shown on the slide, slippage of the bones, spondylolisthesis, as shown in that second MRI scan. And sometimes in those patients that will require fusion, that's the X-ray on the right that shows the screws and the rods. And as you all know, once you need a fusion operation, there's a risk also of requiring more fusion surgery because you put more stress on the levels above and below. So obviously it makes sense if you can intervene early on with some kind of biological intervention, and you can cut down, you can prevent that pathway to progressive degeneration, you can avoid in these patients potentially having to do a fusion. And that's why we started doing research. I work with one of my colleagues at Ithaca, at Weill Cornell University upstate, who is a biomedical engineer, Larry Bonassar. We started research about 13, 14 years ago together, where we work on approaches to use biologics to repair, regenerate, and replace diseased discs. And we just came out with this book, which is really actually the first book that covers this topic in the scientific community, Biological Approaches to Disc Repair and Disc Regeneration. Now, if we go to the next slide, obviously in this book, we cover everything that Ricky so very nicely explained in his introductory remarks. Stem cells, progenitor cells, what does that mean? Let's go to the next slide. And again, I'm a surgeon, so I look at it from a very surgical perspective, but everything that Ricky told you about using stem cells even before surgery, a lot of that can be done as part of an operative procedure. For example, in this case, this is a patient that we treated not too long ago, or this is the MRI scan of a patient who we treated not too long ago. Again, this patient has, and maybe Ricky, you can point that out, this patient has an L5S1 disc herniation. You can see that on the MRI scan, and that patient had severe right-sided leg pain and leg weakness. But you can also see that not only is there a disc herniation, the disc looks very, very dark compared to the other discs, and that means that that disc is degenerated. So again, this was a young patient, only 25 years old. So this patient is at significant risk over time, over 5, 10, 15, 20 years, to potentially develop more degeneration, back pain, and all these other problems that we talked about. So we devised a strategy based on some of the results that Ricky indicated and some of the research that we've been doing in some of these patients to actually use the patient's own stem cells at the time of the surgery when we do the microdiscectomy to augment the disc with the patient's own stem cells that we harvest in the operating room from the iliac crest through the same incision that we do the surgery. We take the stem cells, we spin them down, and in a small syringe, we inject 1 or 2 cc's of those cells into the disc in patients who have what we call a contained disc herniation, or where the disc overall is relatively intact. And we collect data. This is part of a research project. The other project that we work on is, and this is really more experimental at this point, is annulus fibrosis repair.
Roger?
Yes.
Maybe you guys are presenting fabulous information, but it is
so
a
let's
lot.
go to the question.
And I think that it's great to sort of break it down little by little. So if we talk about that particular case, the young woman
Yes.
with a herniated disc. So the indication for the stem cell there is not the herniation. Is that accurate?
That is exactly right. It's really the stem cells are not to treat the patient's current symptoms, but the stem cells are really the attempt to prevent future degeneration of their disc and future back pain, because we know that the presence of a disc herniation sets her up for back pain down the line.
So we have a number of questions, and several of them talk about degenerative disc disease. And how do you determine, and first I ask you, Roger, and then Ricky, if you could chime in as well, what are the criteria that you use to determine that it's degenerative, and then what are the ones that would benefit from stem cell?
Yeah, maybe I'll start. I mean, in these patients that I see, they all have significant problems to start with, of course. If you just see something on the MRI scan and the patient doesn't have any pain, there's no reason to treat it at this point, because it's just not, the risk-benefit ratio is not there. However, in that particular case, if you go back one slide, Ricky, I'm sorry, but if you just show that patient, he has a herniated disc. So that patient needs an operation because the patient has leg pain and leg weakness. So while we're there, there's no downside of using the power of stem cells to try to augment that disc, because we know statistically that this patient is at risk of developing pain 5, 10, 15 years down the line from the disc degeneration. So those are the patients that I see. Ricky has other criteria.
Yeah, and while I have you on the surgical approach, let's say that there was the herniated disc at L5S1, degeneration there, and also at L4-5, but no herniation. Would you inject at L4-5?
If that's a very good question, and that is something that we discussed, and we haven't done that yet. But we could offer, if again, keep in mind we're collecting data. This is not FDA approved. We don't have firm proof that this works. But as we get more encouraging data that this actually really prevents degeneration and back pain, the next step would be to do exactly what you just talked about, namely to offer this as prophylactic treatment in patients who may not even have back pain yet.
So Ricky, I opened that same question to you about indication of degenerative disc disease. And while we're on that, a related topic that keeps coming up is this an alternative to surgery? And, and that's sort of a controversial question. So I wanted to see your thoughts.
The first part, excuse me, the first part is the phrase degenerative disc disease. A lot of people on this panel and in this webinar today have read their MRI reports, and radiologists will often say multi-level degenerative disc disease. I don't like to use the word disease because that's like saying getting white hair is a disease. It's not a disease, it's just part of the aging process. All of us with time are going to shrink in height. That's what happens. The reason for that is those white juicy discs that you saw earlier, right here, these white discs, they will gradually turn black and get dark and decrease in height. And we used to call that disc disease, but that's just saying we are aging slowly. But to answer your question on, do we need to do anything about it? Again, it's based on symptomatology. If we get an MRI on everyone on this webinar today, 270 people, probably 2/3 of us are going to have what's quote unquote degenerative disc disease and have no symptoms. And if you have no symptoms, let's not do anything about it. To the point that Roger was making about prophylactic treatment, I think that's where that opportunity exists. Every other specialty has said, GI has said, come when you're 40 or 50, get your colonoscopy just to check things out. Cardiology says, come get your EKG every once in a while just to check things out. In spine health, we don't really do that. We kind of wait for something bad to happen, wait for pathology, have the patient come to see us, and then we intervene. Maybe in the future we won't do that. Maybe we'll get some type of scan and inject these prophylactically to prevent degeneration in the future.
That's an interesting point. I think, in fairness, reason why we don't get MRIs sort of prophylactically is because it may lead to treatment that also gets problematic. But
sure.
But that is an interesting thought there. Another question that came up was the role of this in spinal stenosis. Do you see any thought on that from either of you?
I'll start, but I'll let Roger finish as well. The problem with a mechanical compression, even when there's a disc herniation pinching the nerve, or spinal stenosis where the spinal canal that houses all the nerves from the spinal cord that go into your legs, that canal is getting squeezed, it's getting narrowed. So if something is being compressed, the last thing I want to do is go in and put some cells or growth factors that are going to increase taking up space. So when there's a compressive issue like a pinched nerve, like sciatica or spinal stenosis, I think that the best treatment is to decompress, whether it's with physical therapy and yoga, maybe an injection, but oftentimes these patients respond really well to surgery. But I don't see, even in the data, that an indication for stem cell procedure is spinal stenosis.
Roger, any thoughts?
Yeah, I would agree. The problem here is that there's mechanical compression of the nerves, and the cells are not gonna treat that. The cells may treat some of the inflammation that may sometimes go along with that, just as steroids would, but they're not going to treat the underlying problem, which is the mechanical compression.
So, another theme that seems to come up is people are looking for answers on whether this is a surgical alternative, and I think you guys have done a great job answering that not so. But but a lot of post-surgical related questions, that they still have pain or they have severe post-operative pain, or maybe adjacent level disease. Is there a role for any sort of biologic in that?
Well, to answer the first part of your question, I mean, there are some cases where these can be an alternative to surgery, like in the example where that disc is actually painful. It's not compressing any nerves. It's not causing radiating pain down the leg. So there's really no surgical indication. There's nothing to decompress, but the disc itself can be painful, called discogenic pain. In those patients, putting something into the disc like a stem cell or a growth vector may be a good indication, and the data actually supports that. In the post-operative group, just like Roger mentioned, if you're fusing or decompressing one level, is there value in prophylactically treating the other? And that's kind of what we're studying. I think the data will show that there is value in intervening early, so there will be less what's called adjacent segment disease.
Right.
Yeah, and I'm looking at some of the questions in the chat box here, and they're really, really good questions. One question was, how long does it take for those cells to really regenerate the disc? And herein really lies, I think, the answer to a lot of the other questions. It takes a long time. It's not something that will work immediately. So, and therefore we only treat patients who have chronic low back pain, a degenerated disc. But once we use those stem cells in these patients, it takes quite some time for those to really take effect. And frankly, we don't know exactly how long. And therefore it is really more for chronic problems. So if you've got an acute disc herniation with severe leg pain or radiculopathy or weakness, stem cells are not the right answer. It's really more prophylactic for chronic problems to slowly regenerate the disc.
The other thing to consider is, managing the patient's expectations. And what I tell patients is, in that black disc that we saw earlier, if we put some stem cells or growth factors, my expectation and my goal is not for that disc to look like the other ones and get larger, the patient gets taller, and that disc gets white again. That's not the goal, because like I said, regenerative medicine versus restorative, which is what we should really call it, we're not going to make new cartilage in the disc, just like we're not going to make new cartilage in the knee joint. So the purpose of these orthobiologics or these stem cell treatments is to enhance the recovery and the healing of what's going on in the disc already. So it's important to have that discussion with patients. And if they're expecting the imaging to look different, that's not the outcome, and that's probably not going to happen.
In order to sort of be fair and balanced here, a great question came up from Dr. Chua. We've talked about some of the fact that this is not FDA approved. What are the typical costs? What are the roles of insurance, if any, in this? How do you counsel patients in terms of where it should be injected? Let's try to break up that question. Let's first talk about what are the typical costs and does insurance pay?
So let me answer the first thing you said about FDA approval. So there are things that we do that are FDA approved for something, and they're FDA off-label for other things. So bone marrow aspiration and injection is FDA approved. We do it off-label when we offer it for regenerative treatments, such as knee arthritis or shoulder arthritis and in spine treatments. So it is FDA approved. We just do it off-label. So FDA kind of leaves us alone when it comes to that. In terms of the costs, yes, insurance does not want to pay for this yet. Insurance usually lags data by many, many years. We need decades of research to show insurance, hey, let's do this instead of maybe an epidural steroid injection that we know works, but also could be deleterious to the body anyway. Geography is destiny when it comes to costs. Here in Manhattan, those costs can range from a couple $1,000s to $20,000. If you go into the Midwest, it could be a little bit less. At Cornell, we try to be very academic about this. And most of the patients that we treat, we enroll in our studies. We have grants to support a lot of these costs because we want to see the outcomes. We want to see if this treatment actually works. And I see some of the patients on this panel. I have treated them with this, and we work with the patient on what's affordable, what I can get away with insurance coverage, what my grants can support. At the end of the day, I want everyone who needs this treatment to get it. I don't want cost to be an issue. But those costs can be prohibitive depending on what practice you decide to go to.
Neel, can I say something real quick?
Yes.
I wanted to ask Ricky a question because a lot of what I see in my practice is obviously spine, but then frequently something that's not necessarily spine. It could be the hip, it could be the knee, it could be the ankle. And that is a very, very important target for biologics that we haven't really talked about. So that's how I look. That's one way for me to look at biologics and the tremendous value of using biologics in our practice at the Spine Center. Maybe Ricky, you can say a few words about the successes of biologics, not necessarily stem cells,
Sure.
but PRP and other things in areas outside but related to the spine that also help us taking care of these patients.
You know, that's a great point. You know, we call this the Center for Comprehensive Spine Care, but so many patients come in who we think is a spine issue and ends up being a shoulder issue or a hip issue. And the data for treating those areas with orthobiologics, which means blood, like platelet-rich plasma or the placental growth factors, the data is far surpassed what it is for spine, because spine regenerative medicine is relatively new, probably 5-10 years. But for joint arthritis and rotator cuff, knee pain, knee arthritis, that data has 20 years of backing. So we talk about that as an option. We first want to figure out where the pain generator is using exam and history and some injections. And then we offer different options. Some of those could be cortisone. Some of them could be gel injections, like, you know, people get fillers and lip stuff, those kinds of hyaluronic acid, or a regenerative stem cell type of product. But this center is comprehensive. We have sports medicine docs here that work as well, because it's not always the spine. It could be something else causing a similar type of pain.
Yeah, well, I think that's really important to understand, that there are roles of other parts of the body that may not have to do with the spine, but can mimic that type of pain as well. To get back to some of the questions, maybe I'll do this as a little bit as rapid fire. Can stem cells regenerate nerves?
That's a great question. There is some recent data that has shown that not only stem cells, but even platelet-rich plasma injected around nerves in patients with diabetic neuropathy or even alcoholic neuropathy has shown to be very effective. So in the central spinal system, nervous system, the spinal cord in the brain, that data is not so great, you know, in talking about paralysis and recovery from that. But in the peripheral system, which is the hands and the feet and the legs, that data shows to be pretty promising.
How about fractures? Even in this particular question, a vertebral fracture.
Fractures is an interesting area because it's growth factors. So in patients who would regularly heal less effectively, probably in the elder adult population, putting stem cells around a fracture site will bring more growth factors to make a callus and bone formation. In the vertebral body, I haven't seen much data because there's already bone marrow and stem cells there. So if it's going to heal, it's probably going to heal anyway. But in the peripheral bones, there has been good data.
And, you know, on that note, we have had discussions in the past about where do you inject it. We've talked about discs and joints. Is that the only place? You know, should it be considered in the periphery? Should it be considered in the vasculature system? What are your thoughts?
So I'll say my 2 cents, and Roger, I'm interested to hear what you have to say as well. You know, I have a colleague at Harvard at Spalding who we have this discussion on a targeted intervention. If it's a rotator cuff tear or a tear in the disc, should I put stem cells just there? And she says, put it everywhere. Put it in the disc, put it outside the disc, put it in the muscles, put it in the ligaments. Because again, these stem cells are specialized. They're already programmed to do what they're going to do. So I'm not worried about them forming bone if I inject it in the muscle. That's not happening. Whatever cells are existing in that normal tissue, they're just going to do their job better. So if I'm treating a joint, I will put it inside the joint and outside the joint and around the ligaments to, again, support the structures. The second thing you asked about, injecting into the blood system, into a vein, and called an IV infusion of stem cells. This is where the FDA does not like that discussion. They come in when they see people doing that and saying, this is not FDA approved. You are manipulating cells more than we allow you to. So we're not going to allow that. And many clinics, many stem cell clinics in the United States have gotten shut down for that reason. Unfortunately, patients do go abroad to get these treatments because they are offered there. But I would exercise caution, really think about it. The data is not shown to be any more effective than putting it peripherally. But certainly that's not something we offer here at Weill Cornell?
Yeah, so I would be careful as well. I would be advising patients to really look at the data out there. Certainly don't go to some exotic institute where there's no track record. If you come to a place like at Cornell where we collect data and we share those data with others, we publish, and everything is peer reviewed, I think that provides a guarantee for patients that everything that we do is being done safely. Personally, myself, my research as a surgeon is really more focused towards growing and building parts of the spine that are important for the reconstruction of spinal issues. We had a slide, if you go back one slide or two slides, if you just go back one slide just to show, these are two discs. One is a real disc from a living organism on the left side, you can see that, and on the right side is a disc made of stem cells that we grew in the lab, just to give you an idea of what our research entails. So we think that in 5 or 10 years, we'll be able to replace the whole disc in certain patients who have, for example, in the neck, a disc herniation. Rather than doing a fusion, we'll be able to actually put in a biologically manufactured, grown disc instead of doing a fusion. So those are the types of indications that I'm working on in my lab. So it's a little bit more in the future. As you can hear, what Ricky does, a lot of what he does is actually something that we're already doing nowadays every day in patients. But again, I think it is very important for a patient to be very, very careful, make sure that you go to the right place where there's oversight and everything has been peer reviewed.
So let's talk a little bit about risks and harm. What should a well-educated person know about the potential downfalls of this, even if done at Cornell?
So when talking about stem cells or regenerative treatments, there's two broad categories. One is what's called autologous. Autologous means I'm taking growth factors or stem cells from you, the patient, and I'm returning them to you. So the risk of rejection and adverse effects are pretty minimal, right? Because it's already your tissues. As long as I'm not manipulating those cells more than the FDA allows me to do, which we don't because the kits that we use are minimal manipulation.
Maybe you can just spend a second on that definition of manipulation.
So the FDA is also a little bit vague about what they call more than minimal manipulation. But basically, if I take a cell or a tissue from you and I break it down with enzymes and chemicals, I've already manipulated it too much. If, on the other hand, I shake it up and clean out all the stuff I don't need and get a nice clean product, that's okay. They allow that. So as long as I don't change the chemical or the structure of the cell, the FDA allows us to put that back into the joint. So in terms of risks, there's minimal risk of me taking your blood. There's minimal risk of me injecting it back other than the standard risks of an injection like infection and bleeding. You know, we do everything with guidance. We do everything in a sterile fashion. So those risks are minimized anyway. When it comes to bone marrow or adipose fat stem cell harvesting, there's a little bit increased risk of getting those cells because we have to do a little liposuction in the abdomen. We have to drill into the bone marrow in the hip. But those procedures are relatively well tolerated. They're pretty benign. The biggest risk I tell patients, honestly, is this may not help if you want to call it a risk. Because after I do all this work, after I put you through this procedure and treatment, you don't get the outcome you want. So I will have wasted your time. And if you want to call that a risk, I would call that a risk. But from a procedural perspective, the risk of spinal cord injury, infection, bleeding are very, very small. Even in the data, they show less than 1%.
That said, though, we've seen a few cases from other institutions come in over the years that had signs of infection, and we've been monitoring. We're actually trying to write that up right now. There's a certain risk of infection with percutaneous injections. Again, you got to do it at the right place with all the safety measures in place because there are risks.
And how do you determine what source you're going to use for this? So you talked about bone marrow, you talked about adipose, so forth, PRP. Is it based on anatomy? Is it based on the point where you want to inject it? Like what factor comes in there?
Yeah, that's a great question. And I think having guidelines that were set up by our spine societies, the Spine Intervention Society, and the American Society of Interventional Pain Physicians. So we've kind of created guidelines on how we should intervene with a regenerative medicine approach. So typically we like to start with what's the most benign, what's the most or the least invasive, which is taking the patient's own blood, just like getting your blood drawn at your doctor's office. That's the least invasive, and the data has 20 plus years of experience. So we start there with PRP. If PRP works well, we can continue that treatment in the future. If it doesn't get us the goal that we want, then we talk about stem cells. And I think of stem cells like turbo PRP, super PRP that's got more cells and more growth factors. The second question you asked about, where do you get it, fat or bone marrow? You know, we just published a paper recently about what's just preferred. The data suggests that bone marrow is a little more effective only because it has stem cells that are more likely to turn into bone type structures like cartilage, like joint space. Whereas adipose tissue does have a higher concentration of stem cells. Some of those stem cells don't do what we want them to do, so they're kind of useless. To answer your question scientifically, there's no great answer. You know, that's a shared decision making with the patient. If they don't have great blood, if they don't have a lot of platelets, I'm probably not going to use their PRP because we're not going to get good growth factors. If they're very thin and they don't have much fat, then I'm not going to do the liposuction because they're not going to have stem cells. So a lot of these factors go into what source we choose at the time.
Roger, how do you look at it?
Yeah, it's certainly for us. It is very convenient and very, very safe, and the FDA supports that to use bone marrow derived cells because you can harvest them in the operating room. And you don't have to grow them afterwards. You don't have to manipulate them, as Ricky explained. That said, though, there are a lot of other options. There are placenta cells from donated placentas or umbilical cord, and those potentially have huge advantages in terms of their anti-inflammatory potency, and that's something that we're exploring right now in experiments. And then, you know, the adipose-derived cells, we used those for a while. There were some concerns from the FDA. That's why we got away from those. So you gotta really look at the research and really keep an open eye because there are a lot of, you know, as you mentioned, I mean, there are a lot of options, and you got to be safe, but also you have to make sure that you explore the potential of other sources.
Is there any advantage to using younger people's donated tissue versus like you, Roger? If I asked from you, would it help me?
I'm pretty young, so I'm happy to donate, Neil.
Age of the cells have a role.
They probably do, but again, for what we do, what I do with my work, which is more surgical, we use the patient's own cells because they're available, they're ready, they're, you know, in the operating room. Those are the cells that we have available. I can see down the line at some point, once we have more data, that maybe we get to a point where we harvest cells from younger donors and then use those later. That is certainly an option. Again, right now, the point is really to make this as safe and as feasible as possible, and therefore it's much safer and much easier to use the patient's own cells.
On top of that, the FDA won't allow us to do that, and there's a chance of rejection of the donor. But the youngest donors that we have are placenta and umbilical vein. And these are structures that we do use in current practice that are FDA approved because they are immunoprivileged, which means they will not cause rejection in the body. So again, if I have an elder adult who I'm thinking about a stem cell or regenerative procedure, I may say to them, let's not use any of yours because, no offense, your growth factors and stem cells might be a little worn. Let's use a off-the-shelf umbilical vein or placenta tissue, which is known to be effective and safe.
Well, we've had still a number of questions. What are outright contraindications? Is there something in the blood, something in terms of history of cancer, things like that, that you say this would really be a bad idea?
The data, again, is a little mixed on absolute contraindications. Certainly if patients have some type of blood-borne disease, you know, either leukemia or low platelet counts, I probably would choose not to use their blood. If they've been on chronic steroids for a number of different conditions, I would probably not use their own cells or own blood. We would choose a allogenic, which means off-the-shelf version. You those are kind of the big two in my decision making when it comes to what source I would use for this regenerative therapy. If they're prone to infections, you have to be mindful. The last thing I want to do, and what Dr. Härtl mentioned, is cause an infection in the disc. That's not a great situation to be in, and the morbidity there is pretty great. So those are some of the reasons and some of the thoughts I would have in discussing this treatment.
There was some time in the past, and this is a number of years back, that there was some controversy of using these therapies, and then if a patient developed a need for stem cell therapy as a cancer patient, they would have a challenge there. Is that still true?
No, especially when we talk about bone marrow. Our bone marrow replenishes in a normal adult. Our bone marrow replenishes the blood and all the stem cells on an ongoing basis. And the amount that we take, this is not a bone marrow transplant like we do for the bloodborne cancer patients or leukemia. We're taking a small sample, maybe 30 or 60 cc's. So no contraindications to future donation or cancer treatments in the future.
So a lot of questions about how do you go about getting evaluated for this, some that don't live in the area. You talked about history and physical. Maybe you can talk a little bit about the role of telemedicine and the discussion of stem cell therapy.
Yeah, Ricky, Neel, from my perspective, and Ricky, from my perspective, that's a very straightforward thing because we have to look at the imaging studies. We have to look at the patient. We have to exclude those particular patients that we just talked about, potential infection, cancer. A lot of that we can do by telemedicine. And I think there's a very, very safe and, again, very convenient way of really assessing patients, not only for stem cells, of course, just for the types of treatments that we have to offer here in general. But I would be very comfortable in giving a patient a recommendation for or against this particular treatment via telemedicine.
Yeah, I echo what Dr. Härtl said. We can do a lot of this virtually to see if you're a good candidate. I see a question here about disc degeneration where there's nothing left of the disc, where the degeneration is so severe, there's no more cells. That is a great question, and that is something we often discuss, and we've published this data in hip arthritis, showing that if the degeneration or the arthritis is so severe, the chance of restoring anything is pretty low. The reason for that is there's no substrate there. There's no cells that exist locally where these other transplanted stem cells are going to exert any effect. So that's a great question. Usually when the degeneration is severe, I don't even offer this because I know the outcome's not going to be great.
And would that apply to a patient that's had a disc removal? I would say you wouldn't. Would you inject in a place that disc has already been removed?
Well, we do that in patients who have a herniated disc, but they don't. In those patients, not the whole disc is being removed, only the part of the disc that's herniated and that's pushing on the nerve. So the majority, more than 80–90% of that disc is still there. And if we're worried about that disc being degenerated, sometimes in selected patients, we can use stem cells to try to regenerate or to prevent further degeneration. So yes, but if you have a patient where you remove the whole disc because you're doing the fusion or something else, then there's no real role for stem cells unless you use stem cells in order to enhance the fusion, which is a totally different application of stem cells that we haven't talked about. So certain stem cells can also be used to enhance bone growth and bone fusion.
While we sort of wind down, a number of questions have come up from people that have had a number of treatments, including fusion surgery, and are still suffering. And how do you counsel them on the role of this? I mean, this is something that I also think about a lot with my patients when I discuss regenerative medicine with them, in that you can kind of tell that they're running out of options or running out of hope here, and they're ready to sign up for something that can be quite expensive. What are your thoughts there?
Well, in patients who had previous spinal surgery and now they're still in pain, obviously, you have to make sure that you exclude everything that could be causing their particular problem. If they had a fusion, Is the fusion correct? The instrumentation correct? Do they develop adjacent segment disease? Is that an infection? I mean, there are a million reasons why people could have potentially back issues after an operation that may initially have been very successful. You got to in a very rational and systematic way, you got to go through all those possibilities to make sure that you're not treating something with stem cells that's actually caused by something totally different. We got to be very careful, because that's how stem cells then would really get a very, very bad reputation if you use them for the wrong indication. And again, the only way to do that is to really be thoroughly evaluated in an environment such as this, where you have a multidisciplinary approach. And telemedicine may not be the good option for that. If somebody had previous back surgery, they really require and deserve a very careful and thorough evaluation by the specialists. And I think it's extremely unlikely that stem cells are going to be the final solution. Usually there's another reason why those patients have pain.
Right. And that's what's challenging. You know, a lot of the patients who are seeking these treatments after failed surgeries or failed epidural injections, you know, kind of become optimistic or even desperate for something that's really going to work. And unfortunately, in this regenerative space, they may get taken advantage of by a lot of practices who over-offer and under-deliver and say, we will treat your neurologic issues with an infusion of stem cells. We'll treat MS and Alzheimer's and a bunch of conditions that, you know, they may not be able to succeed in delivering that care. So we are very thoughtful and mindful on the best patient for this treatment. I have turned down many patients. Dr. Mehta, you and I have shared patients who want to learn about it. They come see me and I say, you know what, you're not a great candidate. It's not going to help you. And that's what we do here, because we want good outcomes. This is not about charging a lot of money, because again, we use a grant to cover a lot of it. But we want good outcomes, and picking the right patient is one way to do that.
So in the last couple minutes, somebody asked a question that gives us an opportunity to be proud of our work. Why should they come to us versus NYU or Mount Sinai? Anybody want to take that one?
Yeah, Roger, you can have that one.
Well, you know, there are a lot of really good institutions in New York, okay? And that's actually good, because it makes us certainly better, because we have to answer exactly to those questions. My answer would be, it's the talent that we have. I mean, and you can see here the enthusiasm of the doctors who are just on this call. It's the breadth of experience. It's the fact that we talk to each other. And the one thing I wanted to bring up earlier when we talked about indications for stem cells is a lot of this is being discussed not only alone in your office, but then also as a group. You know, we have the pain management doctor, the physiatrist, the neurologist, the psychologist. We have all these people sitting together in a conference, go through a particular case, and everybody weighs in. And we try to come up with a common sense and a very well-balanced treatment recommendation. And I think that's different from what a lot of the other institutions do. They may have very, very good surgeons, very smart other doctors, but they don't really talk to each other. So that would be my answer. Plus, we have, a great hospital behind us with all the subspecialties that you need in order to take care of patients with spine problems. So, so a multitude of reasons. But Ricky, Neel, if you have others, please join.
I think, you know, just like you said, in New York, we have many good health institutions, NYU, Northwell, Mount Sinai. It's just a matter of decision-making. Just like Roger said, we are multidisciplinary. We talk on a weekly basis about cases, about patients, to come up with a collaborative approach. I mean, choosing an institution is like choosing what web browser or search engine you use. You can use Google or Bing or Yahoo. I can let you guys decide what I think we are. But the choice is independent and individualized. So I don't think you'd be wrong picking any choice.
Yeah, I like my mother used to say, she says, the proof is in the pudding. I think our awards and reputation in some of the leading organizations that rate centers, place us very high. And I think we're very proud of that, and we're happy to talk about that. All right, so the final thing is, how does one go about making an appointment with you? Well, we talked about telemedicine opportunities. You certainly go to our website. We can help you get appointments there. We'd review your imaging and histories, And we hope that you have found this helpful. Any parting thoughts, Dr. Singh, Dr. Härtl?
No, I think telemedicine is great because, especially if you're not in New York, we can look at your spinal issue. We can meet you in person via virtually, and then we can make a decision. You may talk to me, but then when you come in, I know already that, well, you should get maybe an EMG, you should get an MRI scan, you should also see a Ricky or Neel. We can plan all those things. So telemedicine is really an amazing adjunct to what we've been doing in the past, and it's a very nice way to kind of touch base first.
And certainly, if you've registered for this webinar, we have your contact information, and you have ours. So we welcome new evaluations and consultations. One of the new features that we offer at NYP Weill Cornell is a multidisciplinary virtual visit. So just like you're seeing on the screen with Neel, Dr. Härtl, myself, that could be the patient with all of us in the same room talking about your care. So it's a really nice feature that can get you a comprehensive plan. But yeah, even if you are in New York and you don't want to leave your condo or your apartment, we're happy to see you virtually just to see if you're a candidate for any of these treatments. But do your homework, get second opinions. We encourage that. We want you to make the best educated choice.
Great. Well, I hope everybody has enjoyed this. We certainly do, and we thank you for all your questions and your participation. We will have many more of these. Please stay tuned to your emails for announcements. And this is recorded. You will find it on the web. And I wish everybody a good night.
Bye-bye.
Thanks, guys. Thank you, Neel.
Thank you, Neel. Thanks,
everyone.
Ricky.